If there's something more stressful than trying to find an airway in a toddler in the middle of the night with no help, I sure can't think of what that would be. And so I am really glad to have, as part of our Wrap 'em Just in Time series today, Dr. Marianne Gaucher-Hill, who she's going to be talking with us about pediatric rapid sequence intubation made easy. Dr. Gaucher-Hill is a professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA and Harbor UCLA Medical Center in Torrance, California. She's a nationally and internationally known as a researcher, educator, and leader in the field of emergency medical services and pediatric emergency medicine. Dr. Gaucher-Hill has won numerous national awards for her leadership in emergency medicine, pediatric emergency medicine, and EMS. She's perhaps best known for her study of pre-hospital airway management for children published in JAMA in 2000, and her work on the National Pediatric Readiness Project published in JAMA Pediatrics in 2015 and JAMA Network Open in 2021. She served on the pediatric and main committees for the National Academy of Medicine's Future of Emergency Care in the United States Health System. She's also served as a technical expert panelist for the EMS Agenda for the Future 2050, sponsored by the National Highway Traffic Safety Association. She's a senior director for the American Board of Emergency Medicine. She served as a senior editor for the textbook. She served as a senior editor for the textbook Rosen's Emergency Medicine Concepts and Clinical Practice, and she's the immediate past medical director for the Los Angeles County EMS Agency. She currently is the interim chief executive officer and an active clinical researcher at the Lundquist Institute for She's currently the interim chief executive officer and an active clinical researcher at the Lundquist Institute for Biomedical Innovation at Harbor UCLA Medical Center. I can't think of anyone more qualified to talk to us about pediatric RSI. Thank you so much.
No, thanks for having me.
So, Dr. Gaucher-Hill, imagine that you are not in the C-suite at UCLA, but instead at a critical access hospital, and it's 3 a.m, and you're the only physician in the hospital, and you get a call from EMS, and they say, we are 10 minutes out with a 2-year-old not breathing. After you've taken your own pulse, what do you do to be ready for this kid when they come through the door?
Well, the key thing is you try to be ready before you hear about the incident, but I think having access to a length-based resuscitation tape, I think is going to be really key. Like an example would be the Broslow tape, so that you can quickly utilize that for weight and also to be able to size some of the airway equipment. Through this talk, I'll try to tell you some tips to get you in the zone, which I think is really important. The last thing I want to say is get yourself ready, get your team assembled, and make sure that you have an infant and a pediatric bag literally in your resuscitation areas, and make sure they're always there and always available with massive different sizes, because you never know when somebody's going to walk in carrying a child who's in respiratory failure. So I would do that and then get yourself set and ready for the arrival of the patient.
All right. And I think that's a really important point. This is a just-in-time guide for how you think about pediatric RSI. But a lot of the things that you do in order to be able to do them just in time means you got to have gone shopping for that Broslow tape before the kid is on the way to the hospital. So getting all of your ducks in a row from a preparation standpoint, totally essential. And now you've got your Broslow tape out, you're waiting for that child to arrive. Let's talk about the process of managing that airway.
Okay, I'm going to go ahead and quickly run through these slides. So, I think, first of all, disclosure, you can see that the Wrap 'em projects are supported by ASPR. And I just want to say that all of these comments are my comments and not necessarily that of the United States government, Department of Health Services. All right, getting into airway management, it's really a process. And I think this is a critical piece of information. You start basic, position the head, open the airway. And then you want to add oxygen if anybody's hypoxic. Certainly a limp child who's not breathing is going to be hypoxic, and therefore adding 100% oxygen. You consider what choices you have. Always your go-to is bag mask ventilation. So be ready to do that. Size the mask, bridge of nose to cleft of chin, and then begin good bag mask ventilation with an appropriate seal. And then you have to think about, is this something that is easily reversible, or am I going to need to move to more advanced procedures such as endotracheal intubation with or without RSI, depending on the condition of the patient? And finally, what is your backup? And every ED should have a backup. And with the advent of supraglottic devices, I think we're in great shape with that, because there's LMAs, there's supraglottic devices that can be fantastic in terms of backing you up if endotracheal intubation is unsuccessful. And then finally, you'll always have to, with young children, like a 2-year-old is presented here, think about the possibility of a foreign body and know where your McGill forceps are. Again, that should be part of your airway kit. So really, preparation is the key here, and getting your equipment and staff all ready. And again, having that contingency plan. So this will be part of, basically our take homes at the end. When we think about endotracheal tube size and you see these, complicated formulas and age over 4 plus 4, do you round up, do you round down? What do you do? I say
Yeah,
forget it.
division is the first thing I lose when like CPR is in progress, for sure.
Yeah, and you can't calculate either, right?
Right.
I mean, I think so. I would say forget about this. All right. So I have a pretty simple way of thinking about it. Now, if you're talking about a newborn, I'll get to that in a second. But this is 1, 5, 10 rule is 10, 20, 30 kilos is 4, 5, 6 in a tracheal tube, and you just extrapolate in between. So you got a 2 or 3-year-old, you're 15 kilos and 4.5. You have a 7 or 8-year-old, you're 25 kilos and you're 5.5. End of story. I know that for me, I can only remember 3 things at once. And once I get there, if you give me a 3-year-old, I know 1, 5, and 10 is 10, 20, 30, and I go up. A 3 is between 1 and 5. So I think that's really helpful to stay in the zone. All right, moving on. Everybody always asks me, do I do a Mac or a Miller? Well, I
Mm-hmm.
typically, right? I mean,
Yeah.
like when do you
The
switch
age-old
over?
question. Yeah.
I don't know when you switch over to a Mac, but for me, it's for sure when I get to a Miller 3, I'm thinking about a Mac. So you could use a Mac or a Miller. Some do it at age 2. But I've got a really simple way of doing it. If the baby is literally birthed in front of you or prior to coming in, you're a Miller 0, you could be a Miller 1, right? And I think the key thing for all infants, it's a Miller 1 and then Miller 2 after age 2. And so you start Miller 1 at age 1, Miller 2 after age 2, and Miller 3 3rd grade. And again, you can always swap out a Miller for a Mac, but I like to use the Miller up until school age. So I would say I typically use a Miller up until then. But again, that's your personal preference. So again, Miller 0 is only for a newborn that is birthed in front of you. Even if it's at 5 days, I would use a Miller 1. Again, Miller 1, age 1, Miller 2, after age 2, Miller 3, 3rd grade.
That
All right.
seems like something my maybe 2 numbers at a time mind can manage. So right now you've got your equipment, and it's time to do some sort of rapid sequence intubation, because none of these kids are going to come in with the way I like to see them as a pediatric surgeon, having been NPO since the day before.
Yeah, absolutely. I mean, we don't have that luxury, unfortunately. And so I think this simple way to remember RSI and the steps are oxygenate, sedate, paralyze, and intubate. And then obviously you need a backup plan. We've talked about that. But really the key is to try to keep the pulse ox above 95%. Now, some of these kids are actually spontaneously breathing, but are in respiratory failure. So if you can get by with a non-rebreather and not have to bag, that's great. But if they're apneic or agonal, you're going to need to bag with 100% oxygen. And the goal is to try to get them above 95% before you start the procedure. So I think that's really key. And the one thing, the number one cause of symptomatic bradycardia in children, right, is hypoxia. So we're trying to avoid hypoxia at all costs. Now, people ask me this all the time. Once you start the RSI sequence, and again, if they're not breathing, they have no gag, they're limp, you don't necessarily have to do the RSI procedure. You can just move to airway management and intubation potentially. But for some of these kids that have some tone, you really must just do the RSI sequence. So I'm going to talk a little bit more about that in a second. But how do you keep the oxygenation up? As you know, Rich Levitan, Scott Weingart have been promoting this about adding oxygen by nasal cannula during the apneic period. And I'm a big proponent of this. And then how do you do it? So 1 to 2 liters per year of age, up to 15 liters per minute, like we do in adults, is a quick and easy way of thinking about it.
So you've got them in with a nasal cannula on as you're
Yeah.
bagging them for apnea, just for that additional positive flow.
Yeah, and you're really going to have to compress to make sure you have a good mass seal, because
Right.
that's going to be important around it. But yes, you can do that. If they're fully apneic, again, you'll need to bag. But otherwise, you may just be able to use a non-rebreather. You put the nasal cannula on, then when you start the actual intubation sequence, they're getting oxygen, passive oxygen flow.
Oh, fantastic.
All right. So now sedate. There's many, many drugs that can be used. My go-to are ketamine and etomidate. I will tell you, ketamine, a number of people said, oh, you can't use it in head trauma and you can't use it in other things. But, the studies show that basically you want to avoid hypotension. We call them, basically the H bombs, meaning you cannot have hypotension, right? Hypoxia, really all the things you think of hypos are important in terms of trying to preserve neurologic function. And so really ketamine increases mean arterial pressure, and through that mechanism increases cerebral perfusion pressure. So it's awesome. So I love ketamine. It can be used for bronchoconstriction. It can use with head injury. With hypotension, I recommend ketamine. Without hypotension, you could use etomidate or midazolam. And typically for sepsis, I would use ketamine. So ketamine is my go-to. Very similar that you do all the time with sedation, 1 to 2 milligrams per kilo.
Notably not on that list is propofol, right?
Yeah, I don't use propofol because of risk of hypotension, but it can be used in certain settings like status or things like that. People have suggested its use, but ketamine also might have some anti-epileptic properties as well. So I'm trying to make it simple for everybody out
Yeah,
there. I'd say ketamine and etomidate, and so you have a second agent if you need it.
great.
And then paralysis, succinylcholine works great as long as they don't have muscular dystrophy or have, underlying neurologic issues in which you're concerned about increasing potassium from the muscle, released from the muscle with succinylcholine. Otherwise, you can use rock. And rock is easy because it's just 1 per kilo. For those with succinylcholine, if you notice it's a higher dose, I always use a higher dose for kids because they metabolize it so quickly. So if it takes a little bit, a few tries to get the child intubated, they may actually start not being paralyzed after a number of minutes. So that's why rocuronium is great. And the reason is now we have a reversal agent, Sugomedics. It's Bridion. to get them reversed immediately at 16 milligrams per kilo. If you can successfully bag them, you can use smaller doses, 4 to 8 milligrams per kilo. And it works great. It will be almost immediate if you do a higher dose. Otherwise, it may take a couple minutes. All right. So rock, you can use on anybody, 1 per kilo. So that is cool. I did want to say a couple things here is that with septic kids with really poor perfusion or trauma with really poor perfusion, if they're breathing, oxygenate them and try to fluid resuscitate them first. This is a really hot tip because if you paralyze them and they lose their adrenergic drive, they could go into cardiac arrest. So I like to not, if I can, not intubate right away, but oxygenate. You can even bag them and then start with fluids and then go ahead and do the intubation process, but have push dose epinephrine or some phenylephrine or some other pressor that you can do push dose at your hand. And then you need a contingency plan. For most, it's just going to be maybe you need an airway adjunct and do bag mask ventilation. Supraglottic, they are so easy. You can YouTube it. You can, really the learning curve for supraglottic airway is really short. And again, they are sized by weight. They should have it on the Broslow tape, I believe, a length-based resuscitation tape, but it's pretty easy. They have the weight on the package, and then you can just use the Broslow tape or length-based tape to check out their weight, and then you can put in the appropriate size. You just need to lube it carefully, and essentially you just follow the pallet and go all the way until you meet resistance. You can use video laryngoscopy. That's been a work. Some elastic gum bougies that we use for adults, you really can't use those in kids under 14, but you could use a tracheal tube introducer and potentially try to intubate that way. And then the last ditch is going to be either needle or surgical cricothyrotomy, and that's more in your wheelhouse than mine. So the bottom line is airway management is a stepwise process. Begin with the basics and move on. Always consider foreign body if you feel like there's airway obstruction. And then RSI, structured approach, right? Oxygenate, sedate, paralyze, and intubate, and have your contingency plan. So here's all our take-home points here. And my feeling is, as emergency physicians, you got this, you're airway experts. Just take your time, remember the 1-5 rule, have your tools handy, and take a breath. You got this.
Fantastic. Thank you so much. I think this is just a great review of the key points to know as we take care of these critically ill and scary in the moment patients, but no one's going to help them better than you in that moment. And I will say, having gloved up to do a few crikes, but never actually had to make an incision, I'm always incredibly thankful to the emergency medicine doctors who have gotten those airways before I've had to reach for the scalpel. So
nice. Yep. It's scary, but again, calm yourself down. I love what you said in the beginning, because that's what half the battle is, right? It's just, I got it. Now let's do this.
Fantastic. Thanks so much.
Sure.
All right.